Take Back Your Health Now, Episode 19. You're listening to the Take Back Your Health Now podcast, the show that interviews the top doctors, athletes, trainers, and entrepreneurs to help you find the holy grail of health. Now here's your host, Dr. Dan Margolin.
Hi, this is Dr. Dan Margolin with another segment of Take Back Your Health Now, where we pull out all the stops in search of health's holy grail. We are very excited to have Dr. Pierre on. He is a board-certified internal medicine physician, a fellow of the American College of Osteopathic Internists, and clinical associate professor for Southeastern University College of Osteopathic Medicine and Florida State University College of Medicine. Dr. Pierre has served as a speaker and panelist, touching on a range of issues affecting healthcare and the community in general. Dr. Pierre is available for national, local conference and organization speaking engagements, panel discussions, as well as various media requests. Dr. Pierre, welcome to the show, sir.
Thank you, Dr. Dan. How are you doing?
I'm doing great, sir. So, Dr. Pierre, you're known as a doctor that cares. What do you think a patient should be looking for in the right doctor?
I think one of the first things is, how much time they put in to your personal care. I think right now with healthcare kind of going the way it's going, patients are feeling kind of hostage to their insurance companies. They're feeling kind of hostage to their doctor's office. They're almost feeling like they're in this assembly line processing plant where they're in. They may speak to their doctor for 5 minutes and they're out the room and they don't even really get all of their issues resolved. So I think the first thing foremost is, making sure that doctor kind of puts your care as a priority number one.
No, absolutely. Well, also, I guess to some degree, the doctor may feel that way too, right? Because they're also sort of being squeezed. I guess the patient and the doctor are almost squeezed between the insurance companies.
Oh, most definitely. And I think, and unfortunately in our society, the doctor gets all of the bad rap. Like no one, especially because, again, most patients don't really understand, how a doctor gets paid, first and foremost. So they don't understand that, especially I'm a primary care physician, and I don't really do procedures in my office very much. So I usually get paid per patient I see. So of course, from a business standpoint, I have to see more and more patients to make more and more income. And
it's a volume game.
It's a volume game. And the patient doesn't understand because they just feel like, you're just trying to rush them in and out without, listening to their problems.
Right. I mean, that results in like longer waiting times and all those kind of things that by the time the patient is in there to see you, they're a little bit upset. Their blood pressure is probably elevated. There's certain ramifications for that as well.
Most definitely.
So when you look, you've written that your biggest struggle is balancing public health and your medical side. How do you balance that, and why is that a struggle for you?
I think especially when I started, because I went to Southeastern, and I ended up in their dual enrollment program, MPH, as well as the osteopathic medicine. And I would go to class where we would hear, the greatest discovery, this medications, saving, 20% mortality rate. Like, 20% of people are being saved because of this medication here.
Right.
Then I would, go to my MPH class at nighttime, and they would say, washing your hands cures smallpox across the world. So our standard of, what we feel is success is so skewed when I'm thinking in the public health aspect of it.
And now why is that? Why do you think that is?
I think in medicine, I think we're really not ambitious in terms of how much, we can, quote unquote, prolong life, because that's really most of our endeavor is, how can we prolong life and then give a patient a better quality life? And that's just something that doesn't really seem to come up in the public health world. The public health world considers, if I can't, establish a program that's going to save generations, then I don't want to do it.
Wow. So it's a totally different viewpoint.
Almost definitely. Like I have a professor who he hates medical missions because he feels in the medical mission realm, we go for a week, 2 weeks, provide, the best quality care ever, but then we turn around and leave. Like
Okay.
we give no, foundation to say, hey, now that I'm gone, I want you to do, A, B, and C. Whereas in the public health aspect, he's like, no, I need you to, establish a clinic. I need you to train, the residents there to do the work when you're not there. It's
So
just
it's almost like give a man a fish or teach a man to fish.
exactly.
Okay. And so as you know, being sort of caught between the two, where have you found that your loyalties have been drawn? Which way would you say you've sort of been pulled?
I definitely say I would have to say the public health side aspect of it, and I think I'm kind of skewed because I'm in primary care, so I tend to see a lot of community patients. I tend to be on the front lines in terms of disorders including diabetes, hypertension, high cholesterol, and I tend to be that first person they see before they end up in needing all extensive care, especially when they're non-compliant. And so when they come to me, I'm more of a, well, why is this certain population seem to be dealing with diabetes at a much, rampant rate than this other population? Like that's always my mantra. Like I try not to just focus on the patient, which is
Right.
difficult because, you got the one patient in front of you. But I try to understand, like, okay, this patient population, this culture seems to be affected at a much higher clip. So what can I do that I can, do one teaching that will help spread out to the culture?
Well, it's a little bit what our show is trying to do, right? It's not just looking at seeing the forest for the trees kind of thing, where we're starting to be exterior a little bit to it and looking at how do we change the way medicine is going for the better. I've just been in practice myself for 30 years. The reason I even started with the show is I just saw that with all of the things that we have done, people, in my opinion, are just seemingly getting sicker and sicker. And so I guess in my own way, this show was sort of an attempt to try to halt that or change that a little bit. What do you feel is the biggest threat currently to the health of Americans?
I definitely have to say our drive from a capitalistic standpoint, like now kind of outweighs the health perspective. Where
Wow.
when we think about insurance companies, we think about companies whose unfortunately, and being in primary care, I know I'm kind of skewed, but their sole purpose is really to deny their service. So
No doubt about it. No doubt
so,
about that.
so your job is to take care of patients, pay for patients, but you all of your activities, all of your tactics are really to try to deny. And in a primary care setting where I'm usually, especially I deal with a lot of HMO patients, where I'm always having to get authorizations and I'm always having to prove, even though again I went to medical school, I've got this training, and I'm having to prove to whoever picks up on the line, because sometimes it's a doctor, sometimes it's a registered nurse or whatever type of health professional, that I think my patient needs this procedure, and this happens on a day-to-day basis, every single day.
Every single day with probably almost every single patient.
With every single patient, and their aspect, and a lot of it is computer generated. A lot of it is there wasn't enough yeses versus no's, so a computer shoots back and says, I don't want to take care of this procedure. I don't want to quote unquote pay for this procedure, and that gets pushed down to the physicians. So now the physicians feel this squeeze where now, because I know I have to see more and more volume of patients, now what am I going to start doing? I'm going to start, spending less time with the patients. I'm going to start double booking patients. I'm going to start, trying to get as much in as possible to kind of maximize this revenue. And it's not a bad thing from a physician standpoint, because, hey, we've got loans, I don't even want to talk about my loans, but, we've got loans out the wazoo. So we have to provide income. But unfortunately, we have this kind of, this roof that's on top of us that's really trying to stifle us at every beginning, every step of the way.
Well, I look at several of my associates. They have close to $300,000 in student loan debts. And, that's quite a burden to put on somebody just starting out. They've spent all those years studying, and they come out with that kind of a difficulty. It's just not right.
Oh, no, I definitely agree. And of course, it excuses it, because, again, if I'm walking in with that amount of debt, what's going to happen? I'm probably not going to choose career fields, that pays me on the lower end. And of course, especially when we talk about medicine, they hear our salary, especially the common person hears our salaries, and they're like, oh, what do you mean 150 isn't enough? What do you mean 180 isn't enough? But they don't realize that 150, that 180, that 200 may be coming with $200,000, $300,000, $400,000 worth of loans.
That's right. That's right. I was myself shocked when I sat down with some of my associates. I'm like, well, just tell me, what do you have in student loan debt? And then looking at what the monthly repayment was, and I remember myself coming out 30 years ago, it was quite a burden to bear. But going back to what you said about the insurance companies and when they dictating what you do, I do remember I had a patient come in many years ago, and this was still at a time you could really talk to the insurance companies a little bit more. But they denied a service for a younger patient, and the patient had growing pains, and I felt that they would benefit from an orthotic. The insurance company denied it, so we went with something else. They came back a few months later with the same problem. I called the insurance company, and again they denied it, but they put me through to one of the nurse practitioners or whatever it was at the time. And I said, listen, I have your patient here, and here's how they're presenting. What should I do? And I turned it around, right? And she said, what do you mean? You're the doctor. And I said, well, no, I know what I should do, but obviously you're denying it. So you're now the doctor. I'm putting you down as the treating physician. And I got it approved. That was probably the only time I've been able to change that around. So have you had any kind of similar situations to that?
I do. And, when we try to tell our patients, well, hey, your insurance company isn't, approving it, they look at you like, well, hey, aren't you the doctor? Shouldn't like who do you need to talk to make that happen? Because again, a lot of our patients, because they don't really understand that back end, they just feel like it's I pick up a phone call, someone picks up in 20, 30 seconds, I answer a few questions, and I'm done. But a lot of times, especially with certain insurance companies, I have to schedule a future appointment to talk to the doctor who's ever in charge of authorizing or denying. I have to, again, prove my case, almost like I'm a resident. I have to prove my case again and say, I really think your patient needs X, Y, Z. And then it's, well, I'm sorry, the computer says no. Okay, we'll let that go.
Right.
Right. And that may be a 5 to 10 minute process. So imagine 5 to 10 minute process, and we're already giving our patients 15, 20-minute appointments. That's going to add up very quickly.
No, and it really it's one of the things. I have another company that teaches organizational skills to doctors because they cannot survive now because of the amount of bureaucracy that's thrown on them. But Doc, where do you see medicine going? The nice thing is you have this sort of exterior viewpoint. You're seeing both sides of the coin, so to speak. Where do you see medicine 5 years, 10 years, 20 years down the line?
I think first and foremost, I believe patients are. And they're already starting. They're already starting to get extremely kind of upset with the system in general. And I think what's going to be a big driving force is that you're going to have right now it's kind of taboo when we talk about concierge medicine, direct primary care medicine, or direct care medicine, not even primary care, because I have some specialists who are now going into that cash route. And I think more and more patients are going to end up choosing those routes. Because one, it comes with less bureaucracy. It comes with spending much more time with their physician, and they just have a perception that they're going to get better care.
And how does that work? How would something like that work?
From a primary care standpoint, you have certain, especially in South Florida, we have a few practices where a patient will pay a monthly stipend to have pretty much have access to their primary care physician. Usually when they need appointments, their appointments are an hour long. Usually these physicians tend to have much less from a census standpoint. You have, let's say from an average, a busy census from a primary care physician may be 3,000 to 4,000 patients. Your direct primary care, your concierge medicine physicians may have 300 to 400. So they have much more time to spend with you just to talk and kind of, get to the problems with your health concerns. And then because of the direct primary care, they tend to negotiate directly with laboratories in the area to get their blood work done. They tend to directly negotiate with imaging centers in the area to get much cheaper imaging costs from that standpoint. So they tend to try, they almost act as if their own insurance company. But instead of you paying we won't name those insurance companies. You pay them directly.
Gotcha. So it's really coming down to the individual.
Yeah, and I think more and more people are doing it. I think the studies been shown that before we felt that only a certain demographic, only a certain income level would even go into that type of market. But we're seeing more and more people saying like, hey, if I have to pay, I have to pay this monthly fee to this insurance company anyways. If I could just take some of that and pay it to my doctor, and now I get to see my doctor anytime I want. I get to call his phone anytime I want, which is a misnomer, because even if I tell my patients now, even if I gave you my cell phone number, you would probably only call me during business hours anyways. Like we just know majority of your patients are not going to call you late at night because, again, they still kind of respect your privacy. So even though you've given them the green light to go ahead and call when they need something, they're still not going to do it.
Or even, on my office, our recording is my cell number if you have an emergency, so it goes directly. And I very rarely get bothered. It's really, and it's not a bother. I mean, you're there for the patient. But so it almost seems like medicine, and in a weird way, has come full circle, right? We went at one time to where you would see the physician, you'd have a relationship with them, you would pay them directly, to then somehow the insurance companies put themselves in between that. And it's almost like you're saying we're sort of going a little bit full circle back to that.
I believe so, and especially with a lot of the new health policies that are kind of coming into play, they realize that they made, I don't want to say made a mistake, but they realize that the pay for service in terms of per patient just isn't working. Because that's the unfortunate thing. It's if our healthcare system was working, it was great. I don't think they would do any changes. But they realize that, okay, we're paying to see more and more patients. We're paying physicians and doctors and nurses, everyone, to see more per patient. But we're not getting much better health outcomes. So now,
actually, we that in general, the health in the United States, when they rate it compared to other countries, has statistically dropped over the last 30 years like a rock, and yet the costs have gone through the roof. So, from your perspective, why is that? Why do you see that?
I think a lot of us, a lot of the physicians tend to practice in more of a defensive mode. I think because of this litigious society, we're ordering a lot more stuff that we probably need to. I think we're ordering and almost like the just in case. Like, I just want to just make sure. I think we're relying a little bit less on our acumen from a clinical aspect of it. But then, to kind of put it on the patients, because, the patients, I think, shoulder some of the blame. I think compliance has been an issue for a lot of patients. I think a lot of them tend to use more of the services that tend to be more expensive. A lot of in my own patient practice, I have a lot of my patients, they get, some chest discomfort, and they automatically want to see the cardiologist. They automatically want they automatically want these high ticket items, and they almost taking it out of the initial standard of care. And when you have this society where they can pretty much Google a symptom and say, well, I'm thinking I'm having this, I need to, have this, and this test done. And you spend more time, back and forth saying, no, I don't think you need it. And then what happens, they just end up going to someone else who will do it for them.
So they're actually sort of getting, I guess, whatever kind of media information is out there, some of it not necessarily true, and it's pushing them in that direction. I can imagine then every time you turn on a commercial for such a drug company, and I imagine a lot of more patients are coming with specific requests for specific drugs. Do you see that?
Oh, most definitely. And the companies do that because they know it works. They know that, if we advertise during certain events, if we advertise on certain channels, we know, and then they always say, go ask your doctor. Go ask your doctor. And then, of course, you spend, now remember, we're still going back on our 15 minutes. So now maybe a third of it is now defending a position that, you kind of hold true. Like you say, you know what, I don't think that medication, cures diabetes. But you have to spend 5 minutes just to defend your position from that standpoint.
Well, Doc, let me ask you a question. Just even in terms of that, and in terms of preventative, in terms of nutrition or diet and things like that, I mean, does that also explain why many times when you go to a physician, they're not necessarily either trained in, or they just don't have the time to really go into diet and control like that? You think that's part of the reason, because of the time?
I definitely think time plays a huge factor of it, but I think you're right with the lack of training. I know in our school, I think we had, three in medical school. I think we had maybe like 3 weeks on nutrition. I mean, it wasn't long. It wasn't anything substantive, but yet your patients are coming in with much more knowledge on natural supplements. They're coming with much more knowledge on the latest diet trends. And a lot of times you almost get kind of ambushed because you haven't even had a chance to even read up on the new supplement, the new diet, the new fad that's being presented to you, but you have 3 to 5 minutes to really try to defend your case.
It's not so easy, and also I would imagine with all of this is one of the arguments I've made with all of the bureaucracy that's been placed on the doctors now, with all the paperwork and all of those kind of things, they just don't have the time to look for other ideas and other concepts that might be more appropriate. Is that true for you? Does that seem true?
Oh yes, I definitely agree. I've had many patients kind of enlighten me on certain new treatment regimens and new diets and new kind of ways of thinking. Because again, a lot of times we're seeing so many patients. We really don't have the time, even though we would love to. There's not a physician who wouldn't love an alternative if we know it actually works. Right. But a lot of times we can't even get to the point where, especially from a substantial standpoint, one, we may not even trust, the site that you got it from. That's a problem. You Google, disease, a symptom, and then 100 different sites pop up. A lot of them aren't peer reviewed because they just aren't. So you spend, so again, you almost get blindsided, and then you just don't have the time to even rehash. And trying to get a patient to kind of come back, let's talk about that later. Let's come back in another appointment. That's almost blasphemy for them. They say, hey, I made my appointment. I paid my copay. We need to talk about this now.
Right. Well, listen, you see there's Dr. Joel Furman, Dr. Stephen Gundry. These doctors have written, very well-respected doctors, have written on nutrition, and I think it is turning around. I think you are finding now that the physicians have almost been put in a position where they're recognizing that they can't depend completely on the pharmaceutical companies for their salvation, and they've almost got to make the time, and they've got to find avenues, and they've got to find studies that are correct so they quickly have that correct information. So did you agree with me on that that is starting a trend that's starting to change?
Oh, I definitely do. And, I think the funniest aspect about, especially with the new trends in nutrition, is that our patients, the population in general, have become so distrustful of the system in terms of medicine that, when I prescribe a medication, they think I'm getting a paycheck from prescribing certain medication.
That's right.
So they're distrustful of. So that's one part. They're distrustful of our system of medicine in general, and of course that includes the pharmaceutical companies. That includes the physicians. And they want the alternative. They want to be able to go to these health food markets. They want to be able to eat better and do better and kind of have that control back in their system. I think in the old days, from a patient-physician relationship, it was more, okay, I say, jump 5 feet, you jump 5 feet.
That's
I think
right.
now in our, especially with a lot of patients I'm dealing with now, it's more of this consumeristic idea where okay, I have an idea, you have an idea, where are we going to meet 50-50? Because I'm not just going to just jump because you say jump. I'm not going to take that.
Well, and honestly, I like the concept that the patients are taking more responsibility. Again, one of the reasons we started the show is just I've been getting so many questions from patients that I didn't feel qualified to answer, but I wanted to actually speak with experts like yourself that I could point them in that direction. I could say, listen, I might not know this, but here's somebody that we've looked at, we've spoken with, and they can give you a new concept on it. Dr. Pierre, let me answer. So the show is about really looking for the holy grail of health. If you were to say to your patients, what are some of the things, or what is the thing that would lead them to a healthier lifestyle, greater longevity, greater quality, what would that be?
I think it definitely starts with our diet, because it's the one thing that we come into contact with every single day. And I think with the habits that we've kind of formed just as we grew up, where we eat certain foods, where we eat certain times of the day, we now know has much more long-term chronic effects that we may not even realize when we're 20 or 30 years old.
Right.
So, and in being okay with having a quote unquote healthy diet is something, because before diets, the eating healthy was almost shunned upon in the past. Like it was like,
For
well,
years.
why are you eating that? Like it's like, like why they used to call it almost like rabbit food. Like why are you eating like this rabbit food? Like we didn't recognize like how important what we put in our body, which is funny. We didn't understand how important what we put in our body was to us in health in general. And when we're talking about heart disease, when we're talking about diabetes, when we're talking about cholesterol, we know that there's some genetics component of it, but we know one of the first things, and you probably deal with a lot, one of the first things I say is, well, what can we do from a dietary aspect to change that? Like before you even step into the gym, like what are we going to do about what you eat?
Wow, and it is a different viewpoint. It's something I think it's even medicine is evolving towards, and certainly many of the doctors I've spoken with are giving a very similar answer, which is really great. Dr. Pierre, I want to thank you, sir, for being on the show. How would people that want to know more about you get in touch with you? How would they do that, sir?
Well, yeah, great. Thanks for coming. So I think they can check out my website, drpierresblog.com, where I do weekly blog posts. I also do video posts on my Facebook page at Dr. Barry Pierre, facebook.com/Dr. Barry Pierre as well. Reach out and touch. I'm always available for questions and concerns because again, I think I'm sitting in this show where the public health in me understands that medicine needs to be corrected.
Sure.
So I battle on a day-to-day basis.
Well, we appreciate you doing battle for us, sir. Thank you so much.
Thank you.
This episode is sponsored by New Jersey Foot and Ankle Center in Orodo, New Jersey. Remember, when you have a foot problem, you've got a foot doctor in the family. Weekend and evening appointments are available. Call us at 201-261-9445. Once again, that's 201-261-9445. Thanks for listening. Check out the show notes over at drdanspeaks.com. If you're loving the show, head over to iTunes and leave us a review, and we'll catch you next time. Voiceovers for this episode were provided by Randy Ramos Jr. To see and hear more of his work, visit randyramosjr.com.